afternoon and welcome to our webinar, Making Sense of the Hospice Cost Report. Sorry for the delay, I'm having a little technical difficulties on my end here. So as we begin, there's a wealth of information we'll be talking about today, and this is in regards to the new hospice cost reporting form. So some of the important facts that you need to understand is that effective for all freestanding hospices whose fiscal years began on or after October 1st, 2014, this new cost reporting form takes effect. If your hospice has a 12/31/15 year end, you are required to file using the new form, CMS Form 1984. And your cost report will be due May 31st, 2016. And remember, Medicare does not give any extensions for the filing of cost reports. Information reported must conform to the requirements and principles set forth in CMS Publication 15-1 of the Provider Reimbursement Manual. Part 1 basically defines the reasonable cost of providing services to Medicare patients, including allowable versus non-allowable, requirements to file your cost reports, talks about the allocations of statistics used in the cost determination, and Part 2 of Publication 15-1, Part 2 talks about the general instructions on the cost report in their new form. And this new form can be found in Chapter 43 of the manual. Next slide. Data must be on the accrual basis of accounting. The revenue is recorded in the period earned regardless of when it is collected, and expenditures for expenses and asset items are recorded in the period incurred, regardless of when they are paid. So the key here is, remember that your trial balance should have accounts receivable and accounts payable. Financial and statistical records used on the cost report must be auditable. I know that maybe some of you out there are smaller agencies that are on the cash basis for tax purposes. However, you must convert your books to the accrual method of accounting for cost reporting purposes. Medicare will not accept a cash basis cost report. Next slide. An astounding fact here is that CMS estimates that it will take 188 hours to complete. And this entails reviewing all the instructions, gathering your data, maintaining records, completing the forms. Remember that failure to file a timely and acceptable cost report results in all Medicare payments being suspended until an acceptable cost report is filed. So my recommendation to you, if you are a 12/31 year end and if you have not started to begin the process of gathering the information of your cost report, please start now. So you may want to ask yourself, have you done the following? Have you revamped your chart of accounts? The cost report contains lots of details. Some of you may have requested changes in allocation statistics for worksheet B1, change the order in which specific general cost service centers are listed on worksheet A, and go through the step down on worksheet B. Another thing, if you did request any changes, were your requests granted by your MAC? You may want to check on this. Next slide, please. Update any cost report software you are using to make sure that it's in conformation with the new cost report and the forms. Check your access running the PSNR reports. You must be registered in the EIDM system to access the PSNRs. Is your password up to date? Remember, they change every 60 days. You must change them. I've listed out here the website as to where you would go in and change your password and where you would go in and to access the PSNR. To access the PSNR, remember you want to run report type 810, which is the hospice providers, for hospice providers. And then here's the phone number for the external users help desk. And we'll talk a little later on in the presentation about the annual recertification that's going to have to be done by the security officer. Next page, please. Determine which type of cost report to file. Can you file a full cost report, a low utilization cost report, and this is when your revenue is less than $200,000 for Medicare, or a no utilization cost report. And this is when you have no covered services were furnished during the reporting period and no Medicare claims will be filed for this cost reporting period. Next slide. Yeah, let's talk about gathering some of the information in regards to the cost report. One of the main things you will need are statistics. And some of the key statistics you will need are total days by level of care, by payer. You will need to know the number of contracted days with a facility, and these will be needed by level of care as well as by payer. You will need to gather your CBSA codes. And remember, these codes will not appear on the PSNR. Any time studies for allocations of any salaries, square footage statistics, your gross salaries, your direct nursing hours, mileage, volunteer hours of service, pharmacy charges. Next slide, please. If you own an inpatient facility, you will need the days by level of care. If you own a residential care facility, you will need the days by level of care. And then you will need any other stats, if necessary, to spread any costs within the cost report. Other financial information you're going to need will be your balance sheet, your income statement, your trial balance, and your PSNR report type 810. So moving along to the next slide, remember, this cost report contains a lot of detail. The expenses are by level of care and by discipline. The revenue is by level of care and must be broken out between Medicare, Medicaid, and other payer sources, as well as physician services revenue must be broken out by the 3 levels of care. For this cost report, you have to segregate out your nursing home room and board on both the revenue and the expense side. And also you will notice that there is a separate line for donations and contributions. In the past, some of the agencies would bury these income items under miscellaneous. As we all know, the cost reports are under Freedom of Information Act, and sometimes people just didn't want others to know as to how much they were really taking in monies and donations and contributions. So now let's talk about some of the other expenses that we are going to need and we'll have to look at. Staff transportation, your contracted respite and contracted GIP, your routine medical supplies, your billable medical supplies, your pharmacy costs, your DME and oxygen, labs and diagnostics, patient transportation, nursing home room and board, fundraising, and marketing costs. Next slide, please. So here, this next slide, you can see what all the worksheets are within the new cost report. Some of the key changes here you'll see is if you worksheets A1 through A-4, there is now a separate worksheet for each level of care. Next slide, please. So now let's move on and talk about the significant changes of the cost report. So worksheet S2 now incorporates the former CMS 339 questionnaire. Good thing is the questions have been scaled down. It's probably down about 5 or 6 questions. Again, you must enter your CBSA codes. This is something you will have to obtain from your internal records. There are expanded cost centers under the general service cost centers, the direct patient care cost centers, and the non-reimbursable cost centers. And we'll go through each of these cost centers later on in the presentation. Direct patient care costs will need to be reported by level of care via worksheets A1 through A-4. And then for worksheet B-1, there is expanded cost allocation statistical basis, which will be used in the cost report. Next slide. The other thing is tracking of nursing home room and board. This is new on the cost report. You must report both the revenue and the expenses, and you will be required to do an offset on worksheet A-A, which is the adjustment worksheet. Next slide, please. So now let's talk about our general service cost centers. Basically, the general service cost centers include expenses incurred in operating the program as a whole that are not related directly to patient care. These costs are reported directly on Worksheet A. Next slide, please. So here you will see a list of all the general service cost centers. So just take a moment, take a look at the list. You'll see that prior year on the old hospice cost report, there were 6 general service cost centers. Now there are 17. So there's a lot more wealth of information, a lot more detail that you're going to have to break down within this cost report. Some of the new key areas that they added would be the employee benefits. This now goes into a general service cost center. There's no longer a separate column on the cost report for the benefits. So moving along, let's talk in depth about some of the general service cost centers. So line 1 is our capital related cost, building and fixtures. This is where you would report any of your rent, building insurance, depreciation of facilities expenses. You must also include your inpatient facility costs here. However, you would exclude residential care facility when the unit is separate and distinct and is used for residential care services only. Those costs would then be recorded on line 66 of the cost report, which is the residential care line. You may have to do some pre-allocation of expenses if the inpatient facility does both routine and continuous care as well as GIP and respite inpatient. If a residential care facility houses your entire operation, the nurses go to the outside the residence to visit patients in their homes in the community. So it's just some things that you need to think about as you're putting your cost report data together here. Line 2 is the capital related costs for movable equipment. Again, this would be for leases, depreciation, personal property taxes. You're going to have the same issues whether you have an inpatient unit or residential care facility as you would for line 1. So line 3 is our employee benefits. This is where you will report all your payroll taxes, your pension, your health insurance, your workman's comp, etc. And this will go through the step down on worksheet B. It's no longer going to get allocated directly on the worksheet A. It's going to go through a step down, through a statistical step down on worksheet B-1. Line 4 is our administrative and general costs. And these costs are administrative in nature that benefit the entire entity. Examples, accounting, legal, HR, data processing, office supplies, etc. Do not include marketing and advertising costs that are not related to patient care, fundraising costs, or other costs that should be reported in a non-reimbursable cost center. And there is a separate line on the new cost report for your marketing and advertising costs. Line 5 is plant operation and maintenance. This is where you would record your utilities, your repairs, cleaning, maintenance, etc. Line 6 is laundry and linen. This is commonly seen if you have an inpatient facility or a respite. So most of you smaller agencies, if you don't have an inpatient or a residence, you won't have any costs to report on line 6, 7, or 8, which is line 7 is housekeeping and line 8 is dietary. Next slide, please. Line 9 is our nursing administration cost center, and this cost center includes the cost of the overall management and direction of the nursing services. Do not include the cost of direct nursing services reported on lines 27 through 29. The salary cost of direct nursing services, including the salary cost of nurses who render direct service in more than one patient care area, is directly assigned to the various patient care cost centers in which the services are rendered. So lines 27, 28, and 29 would be for your nurse practitioner, your registered nurses, and your LPNs. A key here is to remember that in carving out your costs, that registered nurses are separated now between RNs and the LPNs. There's two separate lines for your nursing services under the direct care patient cost centers. Next slide, please. So moving on, talking about some of the other general service cost centers, line 10 is for our routine medical supplies. And this would be where you would record items such as gloves, masks, cotton swabs, i.e. items that are not traceable to an individual patient. The key here is that these medical supplies are not patient specific, and that's how you should remember what goes into routine versus non-routine, whether it's non-patient specific or patient specific. Line 10 is our medical records, and this is where you would record the cost of personnel handling the medical records. Line 12 is staff transportation. This is mileage paid to employees, any vehicle lease costs. Do not report patient transportation costs on this line, as they are reported on line 39 under the direct patient care cost centers. Next slide, please. I apologize to you too for having this keep saying next slide, please. I had some technical difficulties with my computer, and I cannot see my computer screen, so I'm just kind of going off the actual printout of the PowerPoint presentation here. So as we move on, let's talk about line 13, which is the volunteer service coordination. The salary cost of volunteer coordination is as well as the recruitment and training cost of all the volunteers. All other volunteer costs would then be reported on line 61, which is the non-reimbursable cost center for the volunteers. Line 14 is pharmacy. This is for the cost of drugs, both prescription and over-the-counter, personnel and services. Do not report the cost of chemotherapy. It is reported on line 45 under the direct care service cost centers. And this is one area that pharmacy charges, you're probably wondering why it's classified as a general service cost center. It's been brought up with CMS. We feel that it should be moved down under the direct patient care cost centers, but as of now, CMS has not moved it, so it's still reported as a general service cost center, and it will then go through the step down on worksheet B-1 based upon your pharmacy charges. Line 15 is for your physician administration services, and this is the cost of the medical director and physicians of the IDT team who participate in the establishment, review, and updating of plans of care, supervising care, and establishing policies, conducting face-to-face encounters for recertification. Next slide. Line 16 is all other general services. And line 17 is patient residential care services. You don't actually report any costs on line 17 on worksheet A. This line 17 is primarily used through the step-down methodology, and that's if you have like an inpatient unit where you're both doing both residential care and you're doing inpatient. The costs would get carved out via the step-down. So now let's move on and talk about the direct patient care service cost centers. The direct patient care costs are reported by line on worksheets A1 through A4. These costs are then summed up and put on worksheet A. Costs are captured by level of care by discipline. So here's a list of the direct patient care service cost centers. I'll just take a moment to take a look at them. You'll see that there are many expanded cost centers here. You'll see you have a line for your inpatient care, which is contracted, your physician services, your nurse practitioners, your RNs versus your LPNs, all your therapy costs, DME, oxygen, patient transportation, your medical supplies, which are non-routine, so remember patient-specific, any outpatient services, your radiation, and your chemotherapy. Next slide, please. So as we move forward, let's talk about the direct patient care service cost centers. And here are some of the descriptions and what some of the costs need to go on the appropriate lines are. And it may help you decide as you're moving forward and preparing your cost reports as to what needs to go on what lines. So line 25 is your inpatient care contracted. So basically this is your cost paid to another facility, whether it's a hospital or SNF, for your inpatient respite or GIP inpatient care. This is the contract rate that you pay to the facility while your patient is there. And remember, this is only for, basically, it's for the cost of the bed. And costs of any services provided by your hospice staff in the contracted setting would then be included in the appropriate direct patient care service line. Line 26 is our physician services, which is the cost of the physician and nurse practitioners providing physician services for direct patient care services. So if you're billing for physician services, you must have costs. If you're not sure, check your PS&R, as it will show you at least a separate charge line if you're billing for physician services. Line 27 is for the nurse practitioner, and this is for the cost of nursing care only. If your nurse practitioner is performing physician care services, those costs must be reported on line 26, which is the physician services. Next slide, please. Line 28 is your RNs, which is your registered nurses. Line 29 is your LPNs or your LVNs. Remember, you must segregate out the cost. So if you have RNs and LPNs, go back. If you haven't done it, go back to your payroll records and segregate out the costs of these personnel. Lines 30, 31, 32 are for your therapies. Line 33 is your medical social worker. Next slide, please. Line 34 is spiritual counseling. 35 is dietary counseling. 36 is counseling other. And these would be other counseling services which are ordered by the physician and they are part of your care plan. Line 37 is for your aids and homemaker services. Line 38 is your DME and oxygen. Line 39 is your patient transportation, i.e. your ambulance services. Line 40 is imaging. Next slide. Line 41 is labs and diagnostics. Line 42 is your medical supplies, your non-routine. Remember, these are the supplies that are specific to a patient's plan of care. Do not include routine medical supplies here, as they would go on line 10 in the general service cost centers. Line 43 is outpatient services. Line 44 is palliative, line 44 is radiation therapy. Don't be confused by the word palliative here. These are for radiation therapy for patients that are on the hospice benefit and not in a palliative care program. And the same with line 45, it's just regular chemotherapy for patients that are on the hospice benefit. Line 46 is for any other patient care services. Next slide, please. So now let's go and we're going to talk about some of the non-reimbursable cost centers as defined in the new cost report. You'll see new this year, there are lines for a palliative care program, a residential care, advertising and marketing, a thrift store, and your nursing facility room and board. Next slide, please. So now let's talk about some of these non-reimbursable program cost centers. So line 60 is the bereavement program, and this would be for costs incurred for services both prior to and after the patient's death. Line 61 is for your volunteer program. However, it does not include the cost of your volunteer coordinator. That cost gets reported under the general service cost centers. The volunteer program costs that you would report here are costs such as for supplies, food for meetings, etc. Recruitment and retraining costs of the volunteers would be reported on line 13, not on line 61. Line 62 is for fundraising. Line 63 is hospice and palliative medicine fellow. Line 64 is for your palliative care program. And these would be costs of the palliative care program to the non-hospice patients, including any physician services. Line 65, which is other physician services, are costs provided outside of a palliative care program to non-hospice patients. Next. Line 66 is residential care. This is the cost of residential care for patients on routine home care, living in a hospice, not receiving inpatient services. This line includes the cost of operating the facility. Do not report any direct care services here, as those would go on the routine home care worksheet. Do not report any laundry, linen, or dietary services here, as those costs would get reported under the general service cost centers. New this year for the cost report is line 67, which is advertising and marketing. And this is for the non-allowable community education, business development, marketing, and advertising costs. And I referenced here the CMS publication 15-1, chapter 21. That's where it talks about your marketing and your advertising costs. Next slide, please. Line 68 is where you would report the cost of telehealth. Include here any salaries of the staff, any leases or depreciation of equipment. Line 69 would be if you were running a thrift store, and here you would report all costs associated with the operation of the store. Line 70 is for your nursing facility room and board, and this is when the patients are on the hospice benefit but they live in a nursing facility. Remember, you must include the full amount paid to the facility, and you must show the corresponding offset of the state payment via an adjustment on worksheet A-8. So it's best that you set up in your books both a revenue and expense side for your nursing home room and board. And it's, as you all know, that you usually only get reimbursed 95% of the rate from Medicaid. Next slide, please. So here's an example of what the new worksheet A looks like, and I apologize that it's kind of small to read, but you can see how it's laid out between your general service cost centers, your direct care cost centers, and then your non-reimbursable cost centers. Now, I hope everybody's still with me. I know this is a wealth of information here. So let's move on, and this should bring us to page 40 on the slides, I believe, worksheet A. So now let's talk about the flow of worksheet A. Basically, worksheet A consists of 7 columns of information. Column 1 is salary, column 2 is other. There's no longer columns for your benefits, for your transportation, or for your contracted services. Everything gets rolled up into column 2, other. Column 3 is a subtotal. Column 4 would show any reclassifications done. Column 5 is another subtotal. Column 6 is your adjustments to your expenses, and then your total is in column 7. So the flow of the worksheet, you basically, any data is directly entered into columns 1 and columns 2 for all the general service cost centers, which are lines 1 through 17, and for all the non-reimbursable cost centers, lines 60 through 71. All the direct patient care service costs, which are lines 25 through 39, will flow directly from the worksheets A1 through A4 for all columns. So remember, the detail for all your levels of care are reported on worksheets A-1 through A-4. Next slide, please. So this page, slide 41, just basically reiterates what the columns 3 through 7 represent. Next slide, which is slide 42, which is your worksheets A-1 through A-4. These worksheets are utilized to record your direct patient care costs by level of care. So remember, we have 4 different worksheets now, A1 through A-4, and there's the list of what applies to what level of care. And again, these worksheets consist of 7 columns. Again, it's your salaries and it's your other, your reclassifications and your adjustments. And the line numbers are consistent on all 4 of these worksheets. So here's an example of what the CMS form worksheet A-2 would look like and you'll see on the left-hand corner it says routine home care. So just take a minute to look at this. So remember, you will have a worksheet A-1 through A-4 for each level of care. Next slide, please. So remember that all direct costs must be broken out by level of care. So if you're a smaller hospice agency, you will typically have your contracted inpatient costs, routine home care costs, and some continuous home care. Remember, the information can be captured by use of time studies, statistical methodologies. You may have to code some of your invoices up front by your AP staff to get the level of detail that you need, or you may just develop spreadsheets for tracking some of the costs. So now as we move on, let's talk about some of the challenges of some of the direct care cost centers. So the inpatient contracted line 25, this is contracted costs paid to the facility, and it's broken out between your respite and your general GIP. So respite is worksheet A3, your general GIP is worksheet A-4. So if you have your hospice staff seeing patients in the contracted setting, so the RN seeing a respite patient would be captured on line 28 of worksheet A-3. She was seeing a GIP patient, it would be captured on line 28 of worksheet A-4. So you can see this might get a little challenging as you begin to gather your data and spread the costs of your personnel. Line 26 is your physician services, and this is direct care only. It includes both physician and nurse practitioners, and this is when the nurse practitioner is providing physician services only. On line 26, you would not include costs of administrative and general supervisory activities such as plan of care meetings, IDT meetings, face-to-face. Next slide. So the nurse practitioner gets reported on line 27. Here, this is for direct nursing care only. Don't include costs of providing physician services. And some of the challenges in capturing the costs would be if your nurse practitioner is performing physician services as well as direct nursing care across different levels of care. How are you going to capture their costs? You may, the costs may need to be captured in 3 different cost centers. So these are just kind of things to think about, and how are you going to get your costs in the proper buckets? Next slide. Your RNs and your LPNs, which is lines 28 and 29. Again, your nursing care must be captured by all the different skill levels. Some of the challenges, by the end of the day, your nurse may have visited a patient at home on routine home care, visited a patient in a SNF for routine home care, and then visited a patient in the SNF for respite services. So how are you going to spread out their time? Next slide. So now let's talk about the therapies, PT, OT, and ST. Lines 30, 31, and 32 of the cost report. Set your payroll up by skill level. You may have to use a time study across levels of care. Most of the time, however, you're going to see these therapies at the routine level of care. And again, you smaller agencies that are basically just doing routine home care and you're contracted GI in respite or contracted, you won't face a lot of these challenges. Medical social worker. The challenge here is, especially in the smaller agencies, a medical social worker can perform an array of duties at various levels of care in various settings. So how are you going to capture her time? How are you going to get her costs in the proper buckets? Next slide. Spiritual counseling, line 34. Your challenge here is your clergy could perform an array of duties, again, at various levels of care in various settings. Are they doing both spiritual counseling and bereavement? Are they on a time study? Alternative use of a patient's date of death is a method to determine the percentage of chaplain visits that are spiritual in nature versus bereavement. These are just some considerations that, as you're putting together your costs and how you're going to get everything into the proper buckets. Next slide. Line 35 is your dietary counseling, and these is where you report your services performed by the dietitian or nutritionist. Line 36 is counseling other. Remember, these is for patient, physician ordered, patient specific. Next slide. Line 37 is your hospice aid and homemaker services. Again, these services can be performed by home health aides, homemakers, CNAs. How are you going to capture their costs by each level of care? Are they on a time study? Line 38, DME and oxygen. This is reporting of the cost by level of care the patient was receiving at the time the DME and oxygen was delivered. Challenge if the level of care changes. You went from routine home care to continuous. You got to proportion your costs. Develop internal spreadsheets. Try to catch it up front as you're coding of the invoices. If you're a small hospice with no owned facilities, the tracking would be just between routine home care and continuous care. If you own a facility and beds were utilized for all types of care, an internal spreadsheet would be more detailed. One of the challenges that we're finding as we're beginning to prepare cost reports is that you cannot report DME and oxygen for GIP in respite care. The cost report right now is the expenses flow does not allow you to allocate costs directly to the DME line. So even us as preparers, we're facing some of the challenges of just trying to get some of the costs in the appropriate cost centers on the cost report. Line 39 relates to patient transportation. This is basically for your ambulance costs. Again, this is a challenge. Your patient goes from routine to respite and back to routine. How are you going to spread the cost of the ambulance service? So moving along here, line 40 through 43 is your imaging services, your labs, diagnostics, and your outpatient services. Again, these costs are very patient specific. It's just a matter of developing spreadsheets in tracking your costs between each level of care. Moving along, medical supplies, your non-routine, which is line 42. These are the medical supplies that are patient-specific in relationship to their plan of care. Again, these must be tracked on each level of care. Lines 45 and 44 and 45 is your radiation and chemotherapy. Again, don't be confused by the term palliative here. These lines are for reporting the radiation and chemotherapy costs for patients who are on the hospice benefits. So now that we have gone through all the general service cost centers, the non-routine cost centers, and the direct patient care cost centers, you can see that there is a wealth of information and a lot of slicing and dicing of expenses that will have to be done to get your costs into the proper buckets on the cost report. So now let's move along. We'll talk about worksheet A-6, which is our reclassification. And this worksheet is used when a shift of cost between cost centers is needed. Examples would be if you needed to reclass medical supplies, needed to reclass any salaries. One thing new and keep in mind when preparing the cost report this year is not only do you have to report the line number, but you have to report a worksheet location number. So the worksheet location number is to reclassify costs that are going through worksheets A-1 through A-4, and those are distinguished by using codes 1, 2, 3, and 4, as you'll see at the bottom of the slide there. So by now we should all be on slide number 59, which shows the actual CMS reclassification form. And as again, if you look all the way over to the right, you'll see that new location worksheet indicator column that I just previously talked about. Worksheet A-8 adjustments. This is where you would enter any non-allowable expenses, anything not relating to patient care. Key questions to ask when considering if expenses are allowable versus non-allowable. The expenses must be prudent and reasonable. Expenses must be related to patient care. There are some differences between GAAP and IRS reporting. And remember, especially a lot of these smaller agencies, you may have your tax returns done on a cash basis. However, for cost reporting purposes, you must report everything on the accrual basis of accounting. Worksheet A, there's a separate line for the state Medicaid room and board this year. And again, there's a locator worksheet column on this worksheet A-8 as well. And again, it would be defined between the subscripts of 1, 2, 3, and 4. So now this should bring us to slide 61, and here's an example of what the actual A-8 adjustments to expenses worksheet looks like. And again, if you look over to the right-hand column, you'll location worksheet indicator, and if you look at line number 10, you'll see that there is the place where you would put the state Medicaid room in board revenue as the adjustment. Moving along, I'm just going to briefly talk about worksheet A-81. Again, this is for related organizations and home office costs. This is where you report those costs and identify those costs. So now let's go to slide 64 and let's talk about worksheet B and worksheet B1, which is the allocation of the costs and the statistical basis of the costs. So worksheet B shows the allocation of the general service cost centers to the level of care and non-reimbursable cost centers. Just note that the line numbers on worksheet B do not replicate those of worksheet A. The general service cost centers and non-reimbursable cost center lines are identical. The direct patient care services are all rolled up into the following lines. They're rolled up into 4 lines. So you'll have a line for continuous, routine, respite, and GIP. For entering the data in column 0, lines 1 through 17 populates from worksheet A, column 7, lines 1 through 17. Line 50 comes from worksheet A-1, column 7, line 100. So that would be your total continuous home care cost. Line 51 would be your total routine home care cost. So that would come from A2. And then 52 and 53 would be your respite and GIP. So then the data for columns 1 through 18 are populated based upon the data from worksheet B-1. So now let's talk about worksheet B-1 and the statistical allocations. And this is the allocation of general service cost centers to level of care and non-reimbursable cost centers. It's based upon the step-down methodology, and there's many changes to the statistical allocation. So now we should be on slide 66, and we're going to begin and talk about these statistical allocations. And you'll see that there's many statistical allocations which have been added to this cost report. Capital-related building and fixtures is done on square footage. Capital-related movable equipment, while CMS said that it was dollar value, they have now clarified it and said that if you have utilized square footage in prior year's cost report, then you can utilize square footage as your statistic rolling forward. Employee benefits is spread on gross salaries. Administrative and general costs are based on accumulated costs. Plant operation and maintenance is based on square feet. Laundry linen is based on in-facility days. Housekeeping is square footage. Dietary is in-facility days. Nursing administration is direct nursing hours. Routine medical supplies is patient days. Medical records is patient days. Next slide. Transportation is based on mileage, or you may have to do some reclassifications here, because if you have A&G staff transportation, you can't allocate directly to the A&G because the step down of staff transportation is after the A&G cost center. Volunteer service coordinator, pharmacy is based on charges. Physician administrative services is based on patient days. Any other general service cost centers, you have to specify what your basis is. And then the patient residential care services is based on in-facility days. So this brings us to slide number 68, and just take a moment to look at the next couple of slides here, and you'll see that it's actually the next 4 slides is the worksheet B-1 and all the statistical allocations that you will now be doing for your general service cost centers. So, and if you look at the bottom, you'll see that lines 50 through 53 is how your continuous routine, respite, and GIP all get rolled up into one line item. So then if you move over to slide number 69, you'll see then you'll go back and you'll have your non-reimbursable cost centers again listed out in depth. And slides 70 and 71 are just the continuation of the general service cost centers that need to be segregated out. And so for any cost that you have in a bucket, you must have a statistical allocation. So now we should be on slide number 72, and just going to talk a little bit briefly about making changes to statistical allocation basis. You can make changes, and any changes from the recommended statistical allocation basis and or the order in which the cost centers are allocated can be made as long as prior approval is granted from your MAC. You must have made a written request to the MAC 90 days prior to the end of the cost reporting period. So if you didn't request any special allocations or moving the cost centers around 90 days prior to 12/31/15, you can't do anything for your 2015 cost report. However, you can request for next year moving on to 2016. The MAC has 60 days from receipt of your request to make a decision, or the change is automatically accepted. If you made any requests this year, what's the status of it? Has it been accepted by the MAC? Some of the recommended changes to be requested for statistical allocations is that nursing administration is done on patient days. However, that is only if your hours are not available. Suggested changes in the order of the general service cost centers is for the plan operation and maintenance, the housekeeping, and volunteer coordination to be moved prior to A&G, because we're finding that you can't allocate costs easily to the A&G cost center. You have to do them through reclassifications. And the other thing that we're seeing out there is that there's inconsistencies between the MACs as to what they are approving and denying as far as the requests being made for these changes in statistical allocations and or the changes in the order of the general service cost centers. So we are seeing inconsistencies with the MACs on these, and we hope to work with CMS and trying to get some understanding and getting the MACs to all be on the same page. So slide 74, we're going to talk about some of the challenges of the statistical allocation basis. Following challenges is presented in the allocation of capital-related building, movable equipment, and plant operation and maintenance. Step down doesn't allow for costs to be allocated to administrative in general or to your direct care staff by level of care. You may have to develop some alternative methods, do some reclasses so that you can get those costs in the proper buckets. Slide 75 is an example of square footage reclassification. So if you have to allocate costs to A&G, for example, as well as you want to allocate some costs down to your RN and home health aide because they're in specific offices, you have specific square feet. Here's an example of the calculation on kind of how you would do that and move the costs around and allocate the RNs and the home health aides based upon a percentage of days. So slide 76 would then show you how you would do the reclassification entry on worksheet A-6. And again, note the far right-hand corner of the slide that you have to do your location worksheet indicator. So in this case, the 2 stands for routine home care and the 1 stands for the continuous home care. So basically what we're doing is we're taking the cost out of your capital related line 1 and then moving it to lines 28 and 37 and then indicating the location indicator as to what is continuous and what is routine home care. Next slide, nursing administration. The statistical basis is defined as direct nursing hours. Thing to consider here is should you include the home health aide and homemaker hours as well, is because in most instances the nursing administration oversees them, so you may want to use direct payroll hours. Staff transportation, again the statistical basis here is for mileage. Doesn't allow for the assignment of administrative staff or direct care staff. Again, you may have to do some reclassifications to get your mileage in the proper buckets. Your volunteer service coordination, this is slide 79. The statistical basis is hours of service. Remember that under the conditions of participation, a hospice provider is required to maintain records on the use of volunteers for patient care and administrative services, including the type of services and time worked. Keep in mind that the structure of worksheet B1 will not allow for the allocation of volunteer time directly to A&G. So you might want to do a reclassification to get that part of your cost into your A&G cost center, and then use the worksheet B-1 in the step down to allocate any remaining hours other than A&G hours to the proper buckets. And just also keep in mind that while there's no formal reporting requirements to CMS on your volunteers hours, providers will be required to produce this information upon survey if asked for. So if you have a volunteer coordinator cost, you should also have volunteer staff. Okay, so as we wind down here towards the end, some of the other key cost report worksheets are worksheet C is the calculation of cost per day, and this is now done by level of care. So not only do you get it by level of care, but you also will still get an average cost per day. Worksheet F is your balance sheet. F1 is your changes in fund balance. F2 is your statement of revenue and operating expenses. And remember that your revenue must be broken out by payer source and by level of care. Some of the key triggers that we're finding on level 1 edits as we prepare the cost report is that days reported on worksheet S1 will trigger edits for your worksheets A1 through A-4. So if you have days, continuous and routine, make sure that you have costs on worksheet A-1 and A-2. If you have contracted days reported, make sure you have contracted days for GIP and respite. Make sure you have contracted GIP and respite costs reported on worksheets A-3 and A-4. And the days also will trigger edits for your revenue, which is on worksheet F-2. Again, remember your CBSA codes must be reported, and again, they will not be on your PSNRs. Worksheet A, column 7, must contain an entry for the following cost centers, or you will get edit messages: employee benefits, administrative and general, plant operation and maintenance, volunteer service coordination, pharmacy, registered nurses, aides, DME and oxygen, labs and diagnostics. So this should bring us to slide 84. Here's a link where you can find the instructions in the CMS website. Slide 85 is the websites for all the Medicare contractors. Slide 86 is the map for your home health and hospice areas and your different MACs. Next slide, we're going to talk a little bit here about the EIDM annual certification. This is for all existing users. Their certification due date was reset to March 15th, and thereafter all existing and new accounts must be recertified by the security official on no less than an annual basis. EIDM will be sending security officials regular emails indicating which of their users are due for certification, when that certification is due, and the instructions on how to perform the certification. You as a security official must respond timely to the recertification request, or your end users will lose their access to the PSNR system. The end users will not receive emails about their recertification. We've confirmed that the emails did go out around February 15th. You should have gotten an email by now from do-not-reply@cms.gov. Have your security officials log into the EIDM system and confirm their profile and that their email address is correct. Make sure that you keep on top of, paying attention when the emails are received, doing the recertifications, changing any passwords, etc. So as we close here, I'm just going to talk a little bit about accessing the PSNR report. To run the PSNR report, here's the link of where you would go to. What you need to do is just accept the terms, enter your user ID and password. Next slide. You would request a report, then you would request the summary. You would then select a report type, and for hospice it is report type 810. Next slide. You would enter your service period. Here you could put in your year interval as well as your start date. Then it will populate down below for each year. For running the 2015 data, it's going to populate 2015 and 2016, so you could exclude any of the future periods over to your right. You want to enter your pay dates. You want to include all pay dates available at time of report generation. And you can select both the PDF and CSV file types. And then confirm your request for your report. And we find that these things query up within at least just a half an hour. If the system's not down, it's pretty quick to go. So that brings me to the end. I thank you for bearing with me. It's kind of difficult when you can't see the actual slides on the screen, so I apologize for that. So I guess at this point in time, we can open it up to any questions that we may have.
Hi, Maureen.
Hi, how are you?
Good. Okay, so I have a few questions I wanted to ask. Number one, my financials are prepared on a cash basis for tax purposes. Can I use the same data for cost reporting purposes?
No. The Medicare cost report requires that you must be on the accrual basis of accounting. So if you need to have your books converted by your accountants because it's cash basis for tax purposes, they must be converted to the accrual basis of accounting.
Okay. Okay, and where can I obtain the CBSA information from?
Okay, that needs to be obtained from your internal systems. They will not be reported on the PSNR, and I can't stress this enough. You need to dig that information out of your systems. You have to put it on the bill so you'll be able to pull it out of your system.
Okay. Also, if I received less than $200,000 in Medicare payments, do I still have to file a cost report?
Yes, you still have to file a cost report. However, you can file a low utilization cost report, and this will consist of basically just the balance sheet and income statement of the cost report, as well as the worksheet S series of the cost report.
Okay. Okay. And I'm also a small hospice provider, and my nursing administrator also makes home visits. Do I need to carve out like the visiting costs?
Yes, you do. The portion of their salary that's related to direct patient care must be broken out by the applicable level of care. And then any of the remaining costs would then stay on line 9, which is the nursing administration line.
Okay. And last question. If the fiscal year end of my agency is December 31st, 2015, is it too late to request a change in the order of the step-down allocation or the statistical basis?
Yes, it is. You could request it for 2016. 2015, it's too late because the changes must be made to the max prior to 90 days before the end of your fiscal year end.
Okay. All right. Got it. Thank you so much, Maureen.
Okay. And thank you, everybody, for attending the webinar. If you have any questions, the last slide has my contact information on it, so please do not hesitate to contact me. And thank you again today for attending our webinar, Making Sense of the Hospice Cost Report.